Welcome to Nursing Grand Rounds. There are no disclosures in this presentation. And welcome Lisa Rea. She's going to talk to us about an HIV overview today for Nursing Grand Rounds.
Thank you. My name is Lisa Rea. I'm a nurse. I work over at Alaska Native Tribal Health Consortium. I want to introduce my coworker, Tor Brentro, who's next to me, who works at South Central Foundation. I don't think you can see him, but he's
Hello.
right next to me. And I have no conflicts of interest to disclose. The topics I'm going to try to cover are HIV 101, just a basic overview. I'm also going to cover the HIV early intervention services, our team, and what we do. A little bit of epidemiology of HIV in Alaska, a little bit of HIV testing and treatment, U equals U, or undetectable equals untransmissible. I'll go a little bit over PrEP, and then at the very end, I'm going to cover what you can do as nurses here at ANMC. So, HIV overview. Just remember that HIV is the virus, and you can't have AIDS without having the HIV virus. AIDS is what happens after the virus has gotten through the body, and it's when your CD4 count gets really low, or you get some other opportunistic infections or other health complications. And this is just a slide about how HIV attacks the immune system. The virus enters the CD4 cells, and it basically causes a dysregulation of the immune system. So the definition of AIDS is when the CD4 count is less than 200, or you have an AIDS-defining condition. And this is a list of all the different AIDS-defining conditions. And unfortunately, we have seen people come in and be diagnosed with HIV and AIDS at the same time and have one of these serious AIDS-defining conditions because they've never been tested. And so they present really complicated medically, and it's harder on them. This is the natural history of HIV without antiretroviral therapy. So initially when someone's first infected with HIV, they have a healthy CD4 count. And then over time it will slowly decrease. This can be different depending on the health of the person infected. If they have other comorbidities, if they use alcohol and drugs, tobacco as well. But this is just kind of an average. So this is without antiretroviral therapy. So the disease progression, we usually call it the acute phase of HIV. The first 6 months, after 6 months, they're chronically infected, and then advanced HIV is when it turns to AIDS. And that can really depend. If people are diagnosed early and they're healthy when they're diagnosed with HIV, they can maintain a normal CD4 count and a low viral load. And the lifespan now for people living with HIV is near normal. Tobacco will actually take more time off people's life than HIV because of the new medications. So now I'm just going to introduce you to our team, the ANTHC HIV Early Intervention Services. We have 2 PAs. Terry Bramall is our program director and clinical specialist. We also have Leah Besh, who works with our program, HIV, and also works with hepatitis. And then we work really closely with the ID doctors here on campus, Dr. Gray and Dr. Schneider. My name is Lisa Rea. I work at ANTHC, and I primarily focus on the rural patients. And then my coworker, Tor Brentro, who's next to me, works at SCF, and his primary focus is the Anchorage-based service unit patients. But as you know, Alaskans travel, so there's a lot of overlap in our patients, and we cover for each other quite a bit. And then we have case management assistants in our office that if you were to call our office, you may end up talking with them. And what we do is we see Alaska Native healthcare beneficiaries here at Alaska Native Medical Center over at internal medicine, so over on the 3rd floor in internal medicine, and we consult and manage anybody with HIV along with their primary care providers here. And then we also see patients with HIV around the rest of the state. We go to some of the hubs and provide field clinics. In other parts of the state, we can see patients that are not Alaska Native beneficiaries. We do a clinic in Fairbanks just where they don't have HIV providers there. And we'll provide case management and core coordination around the state for that. And then we also do a lot of education on HIV and STI for treatment, testing, and prevention. This is what we spend a lot of our time doing, encouraging people to screen for HIV, getting HIV diagnosed early, and getting people linked to care, because getting people diagnosed and linked to care improves survival for them and improves their quality of life, and it also prevents new infections by diagnosing people. a little bit about HIV epidemiology. There's over 1 million infections in the United States. There's about 40,000 new infections every year, and that is slowly declining. We have the tools to do better. We just need to get them in the right places so that people aren't getting infected. But the good news is the lifespan, like I mentioned, is near normal for people who are living with HIV and who take their antiretroviral therapy regularly. So the HIV care continuum in Alaska, there's a little less than 700 people that we think that are diagnosed and living with HIV in Alaska, and that may be people that are diagnosed here or move in from other places. We do pretty well compared to the rest of the country. We're what's considered a low prevalence state. We have about 635 that are engaged in medical care. That means they've seen a provider for HIV once in the last year. And then about 564 that are virally suppressed, and that means that their viral load is less than 200. We do have HIV in all communities all over the state. It's not just an urban problem. It is everywhere. In 2018, there were 22 new diagnoses of HIV. 54% of those were in Alaska Native and American Indians, so they were way overrepresented. There was an increase in heterosexuals becoming infected with HIV and people using injection drugs. We don't have the data yet for 2019. It looks like about, I think, 27 new diagnoses is what they're thinking, and not quite as many Alaska Native American Indian, which is what we had not seen that in past years. It had been a much higher percentage. About 4 of those were diagnosed with AIDS at the same time that they were diagnosed with HIV, so meaning that they've been infected for some time and not known it. And approximately 50% of those were in men having sex with men. We're also seeing it in a younger population, about 70% less than 35 years old. And I think that's what we're seeing in our population as well, young men having sex with men that are getting infected with HIV. So, there was a recent outbreak in the state. There were 6 or 7 newly diagnosed people in a certain area. We'll say 6 or 7 because we're not sure. We think maybe one of the people may have known and come from somewhere else, but just was not engaged in care. 5 of them identified as males who have sex with male. They were either in the military or having sex with someone who was in the military. A lot of them were using the apps on their phone, like Grindr or Craigslist, and there's others that I don't even know the name of, but to meet and partners and have anonymous sex. And so they would think that there was someone there that likely had a lot of partners and was not engaging in care and infected several people. So, other factors that can contribute to HIV transmission, I mentioned multiple partners, time spent in correctional facilities, increased use of drug and alcohol, and using the internet to find sexual partners. HIV testing, it is recommended that HIV routinely be offered for anyone over the age of 13 at least once in their lifetime. And we really say at least once a year, especially for people that are at risk. Testing is voluntary. You do not have to have written consent for testing. You also don't have to provide prevention counseling along with testing. That used to be a recommendation many years ago, and I think providers often felt that they didn't have time to do that. It's nice if they do, but we realize that's not the reality that we live in. So it's more important that the test gets done so that people with HIV do get diagnosed. Let's see, whoops. These are all popping up. So other recommendations, CDC makes a recommendation for the general population. The USPSTF, the task force, makes recommendations for, it's a grade A recommendation, meaning that Medicaid and insurance will pay for it. So that should not be, cost should not be a concern for people getting tested. So we really want people to get tested. There's some barriers. Some providers have a fear of offending patients by offering an HIV test. Belief that patients that they see are low risk or not at risk. We've had people tell us, I asked my provider for a test, and they told me, you don't need this. If someone's asking for it, we really encourage you to do it. Not everyone will share risk factors with you, maybe over time, but not always. And then the lack of time to offer the testing counsel. If you don't have time to counsel, you can still do the test. The counseling can be done later. And then funding and reimbursement, not knowing that the test is covered. We've had a new fourth generation HIV test that we've had for the last couple of years, and it is used here at Alaska Native Medical Center. And it's a antigen antibody test. So that test enables us to diagnose people earlier in their HIV infection than it had in the past. And the screening test, if it shows up positive, it will reflex to a follow-up test to differentiate between 1 and 2. If that's negative, then it will look for a viral load. So you do want to make sure, if you are seeing a positive test, that the screening test has been done, and then look to make sure that the reflex testing has also been done to interpret that result. And this slide just demonstrates how this new test can pick up HIV infection. In the past, we'd have to wait about a month to 6 weeks because we were just looking at the antibody. The line on the bottom is the days following infection with HIV. And so you can see that the green line, the lighter green line, is HIV antibody, and at about 30 days, that would really peak. And that's when we would be able to pick up a new infection with HIV. But with this P24 antigen test, it starts to peak around 2 weeks. So we can identify people in 10 days to 2 weeks. Unfortunately, people often will present with acute HIV in urgent cares or walk-in clinics with rash, flu-like symptoms in that period from 0 to 10 days, which we call the eclipse period, and the test won't pick it up. So if you suspect early or acute HIV, or someone's had an exposure and it's just been a few days, you may want to go ahead and get an HIV viral load to look at that, or at least counsel them to come back in several weeks to be retested. And this slide just demonstrates days from exposure as far as what happens, how the HIV virus travels through your body, enters through a mucosal surface, say through sex, travels into the lymph nodes, replicates in the CD4 cells, and then moves around the body and into the organs by day 11 or so. This is acute HIV, and what when you see a rash or a fever in an adult, that is a red flag for HIV, and I'd really encourage you to test for HIV. Those are not uncommon things to see in kids, but when we see them in adults, that is a red flag. So again, our goal is to diagnose people early, link them to care, get them retained in care, prescribe them medications, and get them virally suppressed. But even before that, we need to address people getting tested for HIV, and that's the bar before all those other bars. And the reasons that we hear for people not testing is provider didn't offer it, they were afraid to get tested, they didn't want to ask for it, shame and stigma around HIV, how family and loved ones may perceive them, or even how the provider will perceive them when they ask for HIV testing. So we really need to address those things first, and we really need to normalize HIV testing in the healthcare setting so that people are open to it. Oops. Okay. So why do we care about finding HIV? Like I mentioned before, we're a low prevalence state, but that doesn't mean we don't have HIV. So low prevalence is not no prevalence. We have it here in Anchorage. We also have it in very small communities. And most people that we're finding diagnosed with HIV, when we look back in their charts, we see multiple missed opportunities where they could have been tested for HIV and diagnosed, and maybe, get them on medications, they'd have a longer, healthier life, but also preventing the transmission to other people. Because most new HIV infections occur in early infection. When people are infected early, if you think back to the slide that had the graph in it that showed the antigen and antibody response, the viral load spikes, the HIV viral load spikes really high when people are newly infected, and that's when they're most infectious, is when they have a lot of virus in their blood. So we want to avert new infections. And then late diagnosis has substantial costs. So screening recommendations: screen everyone, rescreening at least annually or more if people have known risk factors. That includes men who have sex with men, injection drug users, high-risk heterosexuals. High-risk heterosexual would be someone who has sex with multiple partners, someone who has sex with someone who's HIV positive, someone who has sex with a man who has sex with other men, someone who has sex with an IV drug user, someone that comes in for repeat STI screenings, or someone who's repeatedly positive for sexually transmitted infections, history of mental illness, homelessness, history of alcohol and drug abuse, people who travel, and then also people who have transactional sex or survival sex. Having sex for money or having sex for a place to stay or a place for food also puts people at risk. So treatment is prevention. People that are living with HIV that are not engaged in HIV care transmit most of the infections. So the people that are unaware of their diagnosis of HIV are the ones most likely to transmit the virus to other people. When people are in care on HIV medications and with an HIV load that's undetectable, they don't transmit the virus to other people. And that gets us to this U equals U campaign. Undetectable equals untransmissible. And this has been around for several years, and I think providers are finally starting to get comfortable with it. U equals U means having an undetectable HIV viral load means that you cannot pass the virus to a sexual partner. So it decreases the stigma around HIV, and it also encourages people to take their medications. Had patients really get emotional when we've told them that the research now shows if you're on your medications, you're not going to transmit this to other people, because that's something that they've worried about since they've been diagnosed. So it's another incentive to stay on HIV medications. Treating HIV has changed over the years as well. We used to wait for people to get to a certain level with their CD4 counts. Now, we want people on medications as soon as they're diagnosed, as soon as they're ready to commit taking medications daily. So we don't have a cutoff for CD4 counts. If they're diagnosed, we want to get them started on antiretroviral therapy. So anybody living with HIV, oftentimes we'll see somebody for a new visit, HIV visit, they've just been diagnosed, and they'll walk out of the first appointment with a prescription for HIV medications. But they have to be committed to taking their medications. We don't want to get them started if they're not certain that they can commit to taking a daily medication, because we don't want them to take it just kind of part of the time. We worry about them developing resistance then. HIV medication therapy has changed over time. It used to require multiple pills, different times of the day. Different medications had to be stored differently. Some had to be taken with food, some on an empty stomach. Now, most patients, not all, but most patients can get away with one pill once a day. And so that's really nice and changed things for a lot of people. And they have much less side effects than they used to have as well. Sometimes the biggest issue for our patients is they just get overwhelmed. Unfortunately, not all patients can just take one pill once a day. And we have a patient that we've tried, and they really struggle with adherence. And we spend a lot of time counseling on adherence, why it's so important, troubleshooting with patients, how can we get you to take your medications. This is a patient we tried everything with. We delivered his medications to him. They were mailed out to him. We hand-delivered him bottles. We filled pill boxes for him. We eventually got him on the MediSet. You can see those in the back. They were all delivered. One day he came in with all these pills, which probably a month's supply of HIV medications can be $2,000 to $3,000. He came in with all these medications and just said, I am overwhelmed. And rightly so. I mean, he had a lot going on. And unfortunately, he has still struggled with adherence, and he's now suffering from some end-stage complications because of that. But we can continue to try to work with him to get him to take his medications. These are a little bit older guidelines for people living with HIV, and they change regularly, but these are some of the medications that you may see your patients on. Biktarvy is one of the newer medications. It's a smaller pill. Patients seem to like it because it's smaller. It's one pill once a day and has few side effects, and it works really well. And that's one that we're seeing a lot of our patients switch to or even start out on. So adherence is important because it decreases the viral load. When people have virus floating around in their blood, it increases inflammation and leads to more chronic illnesses. So we want to decrease that viral replication as much as we can. Like I've mentioned over and over, it also decreases the likelihood of transmission. It improves their immune system functioning and increases their CD4 count, making them less susceptible to other infections and conditions. It also reduces the emergence of resistance when they take their medications regularly. If they're just taking their medications like half the time or 2/3 of the time, the virus can develop resistance and the medication that they're on won't work for them. And they may no longer be able to take that medication or that class of medications. So we don't want that to happen. And then just some labs that are associated with HIV. HIV monitoring, and when people are initially diagnosed, we want to get a viral load. We want to repeat that again about a month after they've been taking their medications to make sure their viral load is decreasing, make sure the medications are working. And then usually, most people are undetectable after a month on HIV medications. Not always, and sometimes we'll have to repeat it a couple times, but we'll redo it every month or so until they are. suppressed. And we'll troubleshoot too. Are they having trouble adhering to their medications, or do they need to be switched, or does something need to be added? For the first year or two, they'll get a viral load every 3 to 4 months. After 2 years, if they're stable and they're taking their medications and they're doing a good job taking them, they can go to twice a year, every 6 months, getting a viral load. And that's really the lab that we look at to monitor their HIV medication adherence and whether the HIV medication is working for them. We get a baseline CD4 count so we know where their immune system is at and before we start them on medications. And then this has changed a lot because we really used to put a lot into the CD4 count and check that pretty regularly, but it's just not, it's not looked at for changing therapy now. So now if it's over 250, some people won't recheck it again unless something changes clinically. And otherwise we're checking it yearly. And we'll look at a genotype if we can get a genotype just to make sure that the medication that they're putting on, that they don't have any resistance to that. Because some people can acquire resistant HIV. If they get HIV from someone who's been on medications and maybe not done well on medications, you can be infected with a resistant type of virus. And so that would be important to know to get them on the right medication. Other labs that we look at are CMP, CBC, and UA, just to monitor kidneys, liver functions. And then we do annual lipids, TB screening, STI screening annually or more if it's indicated. Vaccinations for HIV-infected persons are important like they are for everybody. We do the routine vaccines for everybody. We want to be careful with live vaccines, make sure people's CD4 count are above 200, but we can give it if it is above 200. Try to give the Shingrix to everybody to avoid shingles. We also give people that are immune compromised and with HIV. All of our patients with HIV are considered with an immune compromising condition, so we give them the pneumococcal vaccine, Pneumovax, and we also give them the Prevnar. We're also giving them Menactra now. And then for HPV, we want to give our patients HPV if they qualify for it, if they're under the age of 45. And for our patients, we give them a series of 3 vaccines instead of 2 that's recommended for others. And then also, of course, an annual flu vaccine. We always try to get people up to date when they come in to see us. So some key points about HIV medication. We like to start it early as possible, as early as patients are willing to start their medications. We do get a genotype, but we can start them on medication and that their meds can be adjusted after that. If patients do have a CD4 count dip below 200, oftentimes they'll be started on an antibiotic, often Bactrim, to prevent pneumonias. We used to put people on weekly Zithromax to prevent MAC infections. That's no longer a recommendation, especially if they're taking antivirals. Just a little bit more about the labs. And a little bit about pre-exposure prophylaxis. Has anybody heard about the pre-exposure prophylaxis?
Yeah.
A little bit? Okay. So PEP is post-exposure prophylaxis. That is taking HIV medications after a single exposure. And so that's when you want to get in and get your medication as soon as someone's been exposed. I mean, they say within hours, even half an hour. It's available up to 72 hours for PEP, but really people need to get in as soon as possible to make it most effective. It decreases over time. PrEP is medication that people take ahead of time in anticipation of repeat exposures. So it's pre-exposure prophylaxis. Oops. So PrEP is, it's one pill. It's typically Truvada, although there is one other medication that's approved for some instances, which is called Descovy, which is very similar to Truvada. It just has a little bit different formulation of the tenofovir in it. But it's been approved since 2012. It also looks like it's offering some protection against hepatitis B and also herpes simplex virus. So it's considered for people who are at risk for HIV, and I mentioned this before, these are the same people we want to test for HIV, but also anyone who asks for PrEP should be considered and discussed with. But men who have sex with other men, anybody having sex with a HIV positive partner who is not virally suppressed, in using injection drugs, commercial sex workers, people that have continual sexually transmitted infections, and anyone who asks about it. So if they have an ongoing risk for HIV, and if they're able to take a pill every single day, the important things when prescribing PrEP is that people get an HIV test beforehand. We want to make sure that we're not giving Truvada or the PrEP to patients that already have HIV, because it would only be a partial treatment. And then they need to be tested for HIV every 3 months and also have labs to monitor their kidneys and liver. And we also want to check their hepatitis B panel beforehand. And adherence is really important. The studies have shown that people who take PrEP, it does prevent HIV infection. So, any questions about PrEP on that?
I was wondering, I had a call recently from a provider, and they said this person was having ongoing risk for HIV. They had just had an exposure. It was outside the 3 days, though, and it sounded like they were going to continue to have the exposure. But they didn't have an HIV test that was back yet, and it was going to be difficult to get this person, back in for appointments. But they were willing to start PrEP now. Would you recommend that? What would the guidelines say? So,
well, I would probably refer them to our infectious disease specialist to see that, but they would probably want to start PEP and then start PrEP if they'd already had the exposure 3 days ago.
So if it's just outside that 3 days window, though.
I would probably refer them to the infectious disease specialist for that.
Okay.
Yeah,
Yeah,
because we
I've
have
heard-
them here. And as far as if anybody wants to reach any of the, has a HIV or PEP or PrEP question, they can just call the main hospital number and ask for the ID provider on call to get
And you
those
guys
kind
know
of questions
Dr. Rea
answered.
and Schneider, probably most of you. Yeah, they're really helpful.
The one thing that we do see with PrEP, people are aware of it. It's advertised a lot. It's on social media. We have patients coming in asking for it now. Primary care providers are prescribing it. But we have seen is it's often young people that are at risk, and they may get it prescribed and either not pick it up at the pharmacy, and then several months later, we have hindsight. We can look back at the chart. We see them with a positive HIV test, or they take it for a month or two, and then it's time to come back in for follow-up labs and to get the prescription renewed for another 3 months, and they don't do that and they don't get it filled. And then they end up with an HIV infection. I mean, I can count probably on more than my two hands how many patients we've had in that same scenario in the last 2 or 3 years, which is really unfortunate.
It's discouraging when we see that. So.
And insurance does cover PrEP, and Medicaid also covers PrEP, so we are seeing it get paid for. So what can you do here as nurses about HIV and HIV prevention? Offer testing to people, encourage people to get tested. If you see that a patient hasn't had an HIV test that you're caring for, suggest it for the provider to order. I think most people would be willing to do that. Educate patients on PrEP. Pre-exposure prophylaxis. When you're taking care of someone or have someone under your care that has HIV, assess their adherence to HIV medications. Are they taking them every day? If they're not taking them every day, what's preventing them from taking them every day? We've had patients before that, well, I don't take my HIV medications when I'm drinking. Well, we still want them to take them when they're drinking. So troubleshooting that with them. We have patients that do really well, that are even, homeless or living in some of the housing first situations where they're allowed to drink. They'll take their HIV medications when they wake up in the morning before they start drinking, and they remain with undetectable viral loads and actually do quite well. We also have a text reminder program where we send out texts just reminding people. It can say whatever they want it to say, just a reminder or whatever, and we have it come whatever time of day they want it to come to remind them to take their medications. Make sure when patients are in the hospital and they have HIV, or if they're diagnosed with HIV in the hospital, that they leave the hospital with their medications. And also that whatever community that they're going to, because we see people from all over here at ANMC, that that we're aware of them so that we can make sure that whatever community they're going to has that medication on their formulary. Because there are some tribal health entities that don't carry HIV medications on their formulary, or some that they only have a few patients and they only have the medications that those patients need. So we may need to make sure that give them a little bit of a heads up, because we don't want people to have gaps in their medication adherence. And make sure patients are aware and connected to services through our program that can help them manage life with HIV. We also have a social service agency here in Anchorage called the Alaskan AIDS Assistance Association, the 4As. They help with a lot of the social needs for patients: housing, transportation, food banks, and just general supportive services. Fairbanks has a similar agency called IAA, Interior AIDS Assistance Association. Encourage STI screening along with HIV, and if someone's coming in for STI treatment, make sure they also have an HIV test that's been done recently. Sexual and risk history taking, asking about sexual health and sexual risks, alcohol, substance abuse. And you can call us with questions anytime too, 729-2907. Or you can just call to let us know that you're taking care of someone that has HIV, let us know that they're inpatient. Sometimes it takes a little while for us to find out that they're here, we may not know. And we like to be able to come visit them and also know that they're here. Sometimes it's an opportunity for us to get them back into care if they've been out of care for a while. Any questions about anything at all?
Do the local agencies provide screening?
The 4A's, the Alaskan AIDS Assistance Association, does do HIV testing. They have certain hours for it, and they use a rapid test, which is not as, the rapid test is good because you can do it in settings outside of a medical setting, and they can do it out at different venues. But it's an antibody test, so if someone were exposed within that month, it may not pick up the test. So it's not as good as the 4th generation test that we have here, but they do those off-site.
Have any of you taken care of HIV patients in the hospital or seen any recently, or that really? Okay. Yeah, if you do though, if you can let us know that they're
Yeah, we
there.
really appreciate just letting know. I mean, we are all kind of separated on campus, but we're all one entity, and we do like to know that they're here because oftentimes we don't know unless we happen to look and then find out, oh, they were here, oh, gee, they were just in the ER and they're due for labs, or they didn't pick up their meds, or, you know, we could have just
Do there any like consultations, like orders, or
you can if they're getting officially referred to us, you can go through the regular referral process through Cerner, but you can also just pick up the telephone and call us, which is probably much easier, just to let us know, and then we'll figure that out for you, because we're usually aware of people and have a relationship with most of the patients, not all of them, but TOR's been around for a long time, since the beginning of the program, which was
what was it, 17 years ago almost?
yeah,
or something?
and I've been here since 2012, I think, so.
Yeah.
And if it's a new patient, we're always happy to come over and meet with them.
Yeah, and a lot of times if they're in the hospital, they've been out of care for a while. Usually, they've had problems with med adherence, so it's extremely important for us to try to re-engage and talk to them, and encourage them to follow up with us and take better care of themselves, and see what gaps they're missing.
And we try to work closely with the primary care providers. We also work closely with the providers down at the Brother Francis Clinic. Sometimes they'll store meds for our patients, homeless patients that may not want to have a whole month's supply of medications on hand because they'll worry about backpacks or belongings getting stolen or lost. They may just go down and pick up a week's supply at a time and fill up a pill box a week's supply at a time. So patients have kind of figured out how to navigate and survive, and it's surprisingly in situations where people can maintain an undetectable viral load and take their medications every day. But we want that for all of our patients.
So what I'm hearing is the PrEP will actually, if somebody with risk behaviors was exposed, then it would prevent the exposure from taking hold? Is that
It would prevent that person from acquiring HIV. If they were exposed to HIV and they were taking PrEP and they had blood levels of the medication in their blood, it's very good at preventing the acquisition of HIV. They did do studies and they found that the people that had the load of medication that looked like they were taking it every day in their blood did not get infected. But when those levels dipped where people were not taking their medication, there were a few breakthrough infections there. So it does work, and it does work quite well. There are things that could decrease it, maybe sexually transmitted infections or things like that, but for the most part it does
you
work.
have to take it. There's no time frame to stop unless you
That's a great question. If someone were to decide that they wanted to go off of it, like say someone were in a relationship with a partner that was HIV positive and that partner was not virally suppressed, so they got on PrEP to protect themselves because their partner wasn't protecting them, we would want them to take it for at least 28 days after their last exposure. That's an excellent question. I'm glad you asked that. So we don't want them just be like, oh, I'm done. I broke up with that person yesterday. I'm stopping it. They need to take it for another.
And that's just what you do with
28 days.
post-exposure prophylaxis too. You take HIV meds for 28 days after the exposure. I ended up going to the ER here one time because of an exposure. I was helping with a lumbar puncture and got a little splash in my eye from a patient that was HIV and Hep C positive, and was not on medication for the HIV, and they had multi-drug resistance to HIV meds too. So I was a little nervous about it. And I went to the ER here, and they were fantastic. The providers and the nursing staff did a great job of having me swallow my first pills within 2 hours or less of the exposure. That's the goal here in the ER, is what they told me, is that 2 hours or less after exposure to take your first meds, and then you take it every day for 28 days or twice
So we
a
don't
day.
want people waiting till the end of their shift. We want people
Yeah,
if they are
just go
supposed
right
to
away.
notify their supervisor right away and go to the emergency
Yeah.
room, because the sooner the better.
And then with HIV PrEP, Lisa, do you want to share how long it takes for it to give you the full benefits?
Yeah, for men who have sex with it, in the rectal tissue, it takes about 7 days. So if someone were to start PrEP today, we would say that after 7 days that they would be protected, 7 days of taking it regularly. For women, it seems to take longer to get into the vaginal and cervical tissue, and also just into the blood, like for injection drug users. And so we say 21 days, so 3 weeks, that we would want people to be taking PrEP before they planned any sort of risk behavior for that. So there is some alternative schedules for PrEP that are taking it, 1 or 2 pills before an exposure, and then another pill 24 hours after, and another one 24 after. They're a little complicated. They're complicated for the providers. They're complicated for us to explain. So we really recommend that people have ongoing risk, that they take it every day, because I think that the others would just be a challenge. Sometimes people know that they're going to have a period in their life where they're going to have risk, maybe before they go on vacation or something like that, and they may plan to get PrEP before that, for several months, and then go off of it. But we want people to know about it because it does work.
And the side effects aren't too bad, right?
No, some people might complain of a little bit of nausea or diarrhea in the beginning, but usually people don't have side effects for after that. And we monitor their labs, like I said, with CMP and CBC to make sure they're not having any toxicity.
And some, staff have told me, oh, well, that's going to encourage high-risk behavior if you have this available for people. So what would you say to that?
Well, I don't know that that's been proven to be true, but, we are having STI outbreaks here in Alaska, so I would, one of the things that we have people do when they come back every 3 months for the HIV screening, and then also to monitor their kidneys and liver, is we do STI screening as well. So that includes syphilis, chlamydia, gonorrhea, because in Alaska we have the highest rates of chlamydia, we have very high rates of gonorrhea, and I could go on and on about STIs, but I think that's for another time. And we're also in the middle of a syphilis outbreak, so we continue to test for those things.
So there's
as
a
well.
lot of high-risk individuals that really should be offered the medication that are not being offered it. That's what we've found. So that would be a good prevention method.
I would not see this medication as being something that would create a more risk behavior. That risk behavior is already
That risk behavior is
Yeah.
already there,
And
right?
so this is going to mitigate future trauma.
It's another
or
tool. I mean, we
sadness.
still encourage condoms,
Yeah.
we still encourage abstinence and monogamy and all those other things, and screening, but it's just another tool to prevent HIV. And, with 40,000 new infections in the US, hopefully we can get this out there and get it to the right people that need it to avoid those infections. I mean, we have new infections here in young people, and it's sad to see, because
It's very
not
traumatic.
necessary.
Yeah.
It doesn't need to be that. But thank you.
Thank you.
Yeah, thank you. That's good.